Good afternoon, everyone. Myself, Dr. Saeed Dora. Today we are going to have a seminar on induction and guidelines for TE in pediatric patient with congenital heart disease and acquired heart disease. To start with, TE has a very integral role in diagnosis and management of congenital heart disease and acquired heart disease in pediatric patients. It can help in complex anatomical structure understanding, functional abnormalities, and flow disturbances. T is used to confirm the pre-op transthoracic echo diagnosis, to have additional information about the other lesions, for de-airing while coming off bypass, to identify the residual or new lesion prior to weaning the patient from CPB, and to evaluate the function and the filling of the ventricles. T is very useful in cath lab, operating rooms, and post-operative ICU in pediatric patients. In this seminar, we are going to see indications, contraindications, safety issues, and guidelines for transesophageal echocardiography in pediatric patients with congenital heart disease and acquired heart disease. To start with the indications are divided broadly in three categories: diagnostic indications, perioperative indications, and TE-guided interventions. Among the diagnostic indications, the first and foremost is suspected congenital heart disease and non-diagnostic transthoracic echo. The presence of PFO with or without agitated saline contrast and direction of shunting as possible cause of stroke. To evaluate cardiovascular source of embolus with no identified non-cardiac source, and to evaluate intra and extracardiac baffles following Fontan, Senning, and Mustard procedures. For acute aortic pathologies, for vegetations and abscesses, for evaluation of intracardiac thrombus before cardioversion or radiofrequency ablation. TE is also used in pericardial effusion and cardiac function evaluation, and for prosthetic valve evaluation and re-evaluation of TE findings for interval change, like administration of anticoagulants and antibiotics, and how it affects the thrombus and the vegetations in the valves. Among the perioperative indications, TE is used for immediate preoperative definition of cardiac anatomy and function, for postoperative surgical results and function, for intra-op monitoring of ventricular volume and function, and for adequacy of de-airing by monitoring intracardiac air. And TE-guided interventions, as in cath labs, it is used to guide the placement of occlusion devices for septal defects, Fontan, or intra-atrial baffle penetration, for the guidance of balloon atrial septostomies, for guidance of creation or stenting of interventricular communications, guidance during percutaneous valve interventions, guidance during RFA, assessment of results of minimally invasive surgical procedures, and to guide the placement of cardiac assist devices. The contraindications, there are some absolute contraindications and there are some relative contraindications. Among the absolute contraindications, the first is the unrepaired tracheoesophageal fistula, esophageal obstructions or the stricture, perforated hollow viscous, active gastric or esophageal bleeding, poor airway control, severe respiratory depression, uncooperative, unsedated patients. Among the related contraindications, if the child is having a history of esophageal or gastric surgery, child with a history of esophageal cancer, esophageal varices or diverticulum, child with a history of recent GI bleed or active esophagitis or peptic ulcer disease, child with a vascular ring or aortic arch anomaly, oropharyngeal pathology, severe coagulopathy or thrombocytopenia, child with cervical spine injury or post-gastrostomy. For guidelines for training and maintenance of competence, there are 4 components: echocardiography. The objective is to prior experience in performing and interpreting the TE, the duration of minimum 6 months or equivalent, and minimum of 450 cases across all age groups should be done. For esophageal intubation, the TE probe insertion, the objective is TE probe insertion, duration is variable, and minimum of 25 cases or 50% under 2 years of age. For TE exam, the objective is to perform and interpret with supervision, duration variable, and number of cases is minimum of 50 cases. And ongoing TE experience to maintain the competency, duration is annual, and number of cases to be 25 to 50 cases per year. Concerns and complications of TE in pediatric patients. The TE insertion can cause a vehicle stimulation, which can lead to sinus bradycardia. And also the probe is to be inserted before the sterile draping is done, so that proper vision of the endotracheal tube can be done. Also, the examination is better to be completed before incision to avoid the electrocautery artifacts. So probe to be inserted before the draping and examination better to get completed before incision. The probe tip, it is better to maintain in stomach during the bypass phase to avoid the esophageal injury. If the probe is to be reinserted during ongoing surgery or by coming off bypass, the risk of bleeding or extubation or cannula dislodgement has to be weighed against the benefit of reinsertion of TE probe. The TE can also cause oropharyngeal dysphagia. It can cause transient but significant increase in cuff pressure during probe insertion, endotracheal tube cuff pressure. Also, in some cases with total anomalous pulmonary venous circulation, compression of pulmonary venous confluence can occur while TE insertion, which can lead to hypoxemia and hypotension, and proper care and concern has to be taken in such patients. For sedation and anesthesia, in intraoperative TE examination, the mostly patient is in general anesthesia. Also, while doing the TE in awake patients, the anatomy and pathophysiology of the congenital lesion has to be considered. In adult patient with congenital heart disease, conscious sedation is preferred. For special consideration is to be given for if the patient is having severe PH or cyanotic heart disease or single ventricle physiology. In adult patient with Fontan, the sedation can cause hydration and venodilatation due to sedation, which can cause hypoxia and hypoventilation, which can further lead to increase in PVR. Paradoxical embolism can also occur because of hypoxia, which increases the right to left shunts, and hence proper filters and proper care to be taken while administering the drugs intravenously. Coming to the probe selection, there are two main determinants while selecting the probe: the weight of the child and size of the TE probe, especially the size of the tip. If the probe is too large, it can cause injury and esophagitis and oropharyngeal injury. If the probe is too small, then poor image quality can occur due to the lower density of piezoelectric crystals and also due to reduced contact with the esophagus. So there are mainly smallest probe is a micro multiplane probes available, which is the smallest. It can be used up to a child of 2.5 kg. The maximum tip diameter is 7.5 mm with 32 elements. In mini multiplane probe, it can be used up to as small as 3 to 3.5 kg child with a tip diameter of 10.7 mm with 48 elements. In adult multiplane probes, it can be used in a child up to 25 kg or greater than 25 kg. The tip diameter is 14 to 14.9 mm with 64 elements. It can be used for smaller children, of course weighing the risk and benefit of a larger probe. The large probe, obviously the adult multiplane probe, will give advantage of better image quality due to greater density of piezoelectric crystals and improved contact with esophagus. As far as 3D TE is concerned, it is unsuitable for young children and can be used only if the weight is more than 30 kg or more. The diameter is 17 mm tip diameter with 2400 elements. Another one is intracardiac echo catheters, which are very small, 8 to 10 French, but it gives imaging in a single longitudinal plane. But because of stiffness and lack of approval, it is not much used. Then there is an intraop epicardial echo when TE is not visible or available. Now coming to the probe insertion techniques. After adequate anesthesia and sedation, probe needs to be inserted very carefully, avoiding the injuries to the oropharynx and the esophagus. There should be appropriate fasting of the child. The probe should be unlocked and well lubricated. Slight antiflexion of the probe will help in negotiating through the tongue. Slight subluxation of mandible will pull the airway and larynx anteriorly, and some reverse cricoid maneuver and guidance with gloved finger will help in insertion of the T probe. Sometimes the use of direct endoscopy is needed to insert the T probe. Experience and expertise will help in distinguishing the normal from excessive resistance faced while inserting the T probe. The positioning of the head to the side will close the ipsilateral pyriform sinus and will help in inserting the T probes. Deflation of the cup temporarily may be needed in some cases. Of course, care to be taken and the cuff is to be inflated immediately after T insertion. Arterial trace may get dampened if the patient is having aberrant subclavian artery or unusual arch laterality. Hence, prior communication is needed and arterial line to be taken in the opposite side. Probe care. Now, how to take care of the T probes. Now, point of care wipe down immediately after removing the T probe. The T probe is to be wiped with superficial to remove superficial material before it adheres to the probe. The probe is to be transported in a container. Is to be to protect the integrity of fragile terminal tube and to prevent the contamination from secretions on the probe. Now, cleaning is done with enzymatic material used, followed by another enzymatic cleaning and rinsing. Manual drying, lint-free drying cloth is to be used. Electrical leakage testing for patient safety. High level of disinfection, whether manual or automated, is used. For rinsing, the instructions of the disinfectant manufacturer is to be used. For probe drying, it is to be done in a vertical cabinet, not touching anything. Storage is done in a HEPA filter cabinet is optimal in a positive pressure HEPA filter cabinet. Transportation, clean and protective container to be used. Now, probe manipulation and controls very much similar to the adult T probes. But obviously the many pediatric T probes will not have the smaller wheel which is used for right to left flexion of the T probe. There will be only a larger wheel for anterior and lateral flexion, anterior and anteroflexion and retroflexion. The other maneuvers which are used for better imaging is forward, the insertion and the withdrawal of the T probes and angle change. There are four main positions from where the image is acquired: upper esophageal, mid-esophageal, transgastric and deep transgastric. Comprehensive imaging examination. The echocardiographic evaluation of children with congenital heart disease is based on structures rather than on views. 28 tomographic views can help in comprehensive T examination of any pediatric patient with or without congenital heart disease and in most adult congenital heart disease. There are four main primary positions: mid-esophageal, transgastric, deep transgastric and upper esophageal. All views are presented with standard apex up orientation except deep transgastric views which are inverted to apex down to present as anatomically correct display. Now, T imaging in some selected congenital heart disease. To start with, in atrial septal defect, what we have to see for location of AHD, size of the AHD, number of AHDs, morphology and suitability for device closure. The views which are used are commonly mid-esophageal four-chamber view, mid-esophageal aortic valve short axis view, mid-esophageal RV inflow-outflow view, and mid-esophageal bicaval and deep transgastric atrial septal view. There can be associated lesions like partial anomalous pulmonary venous return, which can be seen in mid-esophageal right and left pulmonary vein view, mid-esophageal bicaval view, and deep transgastric atrial septal view. It may require extending to upper esophageal and to evaluate superior inferior sinus venosus defect. Left sinus venosus draining to coronary sinus can be seen in mid-esophageal four-chamber view with slight retroflexion, mid-esophageal two-chamber view, mid-esophageal bicaval view, and upper esophageal aortic arch short axis view with slight left rotation of T probes. Now, coming to the VSD patients, the location, size, number of the VSDs to be noted. The views which are used are mid-esophageal four-chamber view, mid-esophageal five-chamber view, mid-esophageal long axis view, and mid-esophageal aortic long axis view, mid-esophageal aortic short axis view, RV inflow-outflow view, and deep transgastric five-chamber view. There can be prolapse of the aortic valve, which is best seen in mid-esophageal aortic valve long axis view, mid-esophageal aortic short axis view. There can be double chamber right ventricle which is seen in medial-esophageal aortic valve short axis view and medial-esophageal RV inflow view and deep transgastric RVOT view. In patients with atrioventricular septal defect, AVSD patients, there is a ostium primum ASD and an inlet VSD, which is best seen in medial-esophageal four-chamber view, transgastric basal short axis view, and transgastric mid-papillary short axis view. The common atrioventricular valve which is present in AVSD patients is best seen in medial-esophageal four-chamber view, medial-esophageal long axis view, transgastric basal short axis view, and deep transgastric five-chamber view, and deep transgastric RVOT view. There can be a cleft in the mitral valve which is seen in medial-esophageal four-chamber view and medial-esophageal mitral two-chamber view and long axis view. For subaortic obstructions, it can be seen in medial-esophageal five-chamber view and medial-esophageal long axis view and aortic valve long axis view. In patients with absence anomaly, the morphology of the tricuspid leaflet and suitability for repair, that is mobility of anterior leaflet and caudal attachment to RVOT and number of regurgitant jets, can be seen in medial-esophageal four-chamber view and medial-esophageal RV inflow view and modified bicable view and transgastric basal short axis view with slight rightward probe rotation. The associated lesions ASD, which can be seen in views as discussed above. There can be non-compaction of the LV, which can be seen in medial-esophageal four-chamber view, medial-esophageal two-chamber view, and transgastric apical short axis view and transgastric long axis view. This is a transthoracic imaging of the LV compaction seen in patients with absence anomaly. We can see LV non-compaction. We can see the trabeculations from LV cavity into the myocardium. Now, in conotruncal defects like TOF, DURV, truncus arteriosus, and TGA, the positions of the great artery, including the conal septal location, whether it is subpulmonary, subaortic, or bilateral, position of the arteries, anterior or posterior, and size, whether it is hypoplastic or absent, can be seen in medial-esophageal five-chamber view, medial-esophageal aortic valve long axis view, medial-esophageal RV inflow view, and deep transgastric five-chamber view and deep transgastric RVOT view. For the location and size of the VSD, whether it is subaortic or subpulmonary or doubly committed or remote, medial-esophageal five-chamber view can be used, medial-esophageal aortic valve long axis view, medial-esophageal short axis view, and medial-esophageal RV inflow view, and deep transgastric five-chamber view, and transgastric mid-papillary short axis view, and transgastric apical short axis view is useful. For associated lesions like for RV size and functions, medial-esophageal four-chamber view and medial-esophageal aortic valve short axis view and RV inflow view can be used. For aortic valve abnormalities, whether it is stenotic or regurgitant, or there is some straddling or overriding, we can see in medial-esophageal four-chamber view and medial-esophageal five-chamber view and medial-esophageal two-chamber view and long axis view and RV inflow views, and in medial-esophageal modified bicable view and transgastric basal short axis and mid-papillary short axis and deep transgastric five-chamber view and deep transgastric RVOT view. For TOF patients in postoperatively, while immediately coming off bypass, residual VSD is to be seen, which can be seen in medial-esophageal five-chamber view and aortic valve long axis view and aortic mid-esophageal short axis view and RV inflow view. For RVOT obstruction, residual RVOT obstruction, we can see in medial-esophageal RV inflow view and deep transgastric RVOT and upper esophageal aortic arch short axis view with left rotation of TE probe. For pulmonary regurgitation, we can see in RV inflow view, upper esophageal aortic arch short axis view with left rotation of TE probe and upper esophageal PA view and deep transgastric RVOT view. For DORV patients postoperatively, residual VSD is to be seen. For LV to aorta pathway, medial-esophageal five-chamber view and medial-esophageal aortic valve is long axis view can be used. It can also be seen in deep transgastric five-chamber view and deep transgastric RVOT views. In truncus arteriosus patients, postoperatively residual VSD is to be seen. Anatomy and function of the truncal valve can be seen in medial-esophageal aortic valve long axis view and medial-esophageal aortic valve short axis view, deep transgastric five-chamber view. For location, size, and function of RV to PA conduit, medial-esophageal RV inflow view and deep transgastric five-chamber view and RVOT view is used. For PA size and residual PA stenosis, medial-esophageal ascending aorta long axis view and short axis view, and upper esophageal aortic arch short axis view and PA view is used. For LV to aorta pathway, mid-esophageal 5-chamber and aortic valve long axis view and deep transgastric 5-chamber view is useful. For TGA patients operated for arterial switch, the views to be used for right and left ventricular outflow tract, mid-esophageal 5-chamber and long axis and aortic valve long axis view and RV inflow view and deep transgastric 5-chamber view is useful. For supravalvular regions, upper esophageal aortic arch long axis view and short axis view and upper esophageal PA view will be helpful. For anatomy and function of neo-aortic valve, mid-esophageal aortic valve long axis view and short axis view will be useful along with deep transgastric 5-chamber view. For coronary reimplantation, mid-esophageal aortic valve short axis view will give you the information. As the associated lesions, coming to the associated lesions, the LV size and function can be assessed by 4-chamber view and 2-chamber view and long axis view, transgastric basal short axis view, and endopapillary short axis view, and transgastric apical short axis view, and long axis view along with deep transgastric 5-chamber view. For TGA patients with Ahd's-Cce, the residual VST is to be seen, the location, size, and function of RV to PA conduit. We can use mid-esophageal long axis view and RV inflow views and deep transgastric RVOT view. For LV to aorta pathway, mid-esophageal 5-chamber view and long axis view, and will be along with deep transgastric 5-chamber view and deep transgastric RVOT view will give you the information of LV to aorta pathway. For TGA patients operated for atrial switch operation like sending and Western, pulmonary venous baffle can be seen in mid-esophageal 4-chamber view, and superior and inferior limb of systemic venous baffle can be seen in mid-esophageal bicaval view, modified bicaval view, and transgastric IVC hepatic veins view, and upper esophageal aortic arch short axis view, and upper esophageal PA view. It may require gradual sweeping in order to scan the superior and inferior limbs of systemic venous baffle, including clockwise and counterclockwise probe rotation. For systemic RV size and function, mid-esophageal 4-chamber view and aortic valve short axis view and RV inflow view will be useful. For systemic AV valve regurgitation, mid-esophageal 4-chamber view and RV inflow view and modified bicaval view will be helpful. For seeing whether there is subpulmonary LV size and function, mid-esophageal 4-chamber view and 2-chamber view will give you the information. In patients with single ventricle physiology, for stage 1 repair for BT shunt, the assessment of the size and the function of modified BT shunt, central shunt or Sano shunt can be obtained by upper esophageal aortic arch long axis view and short axis view and upper esophageal PA view. To assess the PA band, deep transgastric RVOT view and upper esophageal PA view will be helpful. To assess DKS procedure, mid-esophageal aortic valve long axis view and mid-esophageal ascending aorta long axis view and short axis view will be helpful. For the assessment of the Norwood and aortic arch, mid-esophageal aortic valve long axis view, mid-esophageal ascending aorta long axis view and short axis view, and upper esophageal arch long axis and short axis view will be helpful. In BDG, in stage 2 BDG patients, that is BDG, in mid-esophageal ascending aorta long axis view and short axis view, along with aortic arch short axis view will be helpful. In patients with Fontan, atriopulmonary connection can be seen in mid-esophageal RV inflow view and ascending to mid-esophageal ascending aorta short axis view and transgastric IVC hepatic vein views. The lateral tunnel or the extracardiac connection can be seen in transgastric IVC or hepatic vein views and bicaval tricuspid valve view. And pulmonary artery flow can be seen in mid-esophageal ascending aorta short axis view and upper esophageal aortic arch short axis view. If there is a right pulmonary vein compression is suspected, then it can be seen in mid-esophageal right pulmonary vein view. Right atrial clot in atriopulmonary connection can be seen in mid-esophageal 4-chamber view, mid-esophageal modified bicaval tricuspid valve view, and deep transgastric atrioseptal view. Lateral tunnel and extracardiac patency, to check the patency of the tunnel, clot or fenestration is there. Mid-esophageal 4-chamber view and mid-esophageal 2-chamber view along with mid-esophageal bicaval view and transgastric IVC pedic vein view will be helpful. These are some of the images of the lesions. Like subvalvular aortic reach can be seen in mid-esophageal long axis view at 120 degree. There is reach just below the aortic wall, causing the aortic stenosis, subvalvular aortic stenosis. Then there is a patient with Epstein anomaly, showing the in mid-esophageal four-chamber view, showing the displacement of the septal leaflet, causing the atrial lesion of the right ventricle and redundant anterior leaflet. Then there is a mid-esophageal four-chamber view of a patient with chordae atrium. There is some turbulence of flow through the membrane, which divides the left atrium into two chambers here. There is a four-chamber view of AVSD patient showing the ostium primum ASD with common AV valve and the inlet VSD. This is a mid-esophageal aortic valve short axis view showing the anomalous origin of the left coronary artery from the right sinus of Ursava and coronary artery coursing between the PA and aorta can be seen in color Doppler. This is a 5-chamber deep transgastric view of the DORV patient with subaortic VSD, and you can see aorta overriding and getting the blood from both LV and RV. This is a mid-esophageal 4-chamber view showing the DTGA corrected with atrial switch staining, and pulmonary venous baffle can be seen draining into systemic right ventricle. This is a Fontan patient, mid-esophageal bicable view. You can see the Fontan tunnel. Now all the views, entire pediatric examination can be done comprehensively with these 20 tomographic views. Thank you.